So Andrew, we talk about depression, sometimes we talk about bipolar disorder, sometimes we've talked about manic depression. So what are these terms and are you comfortable with these definitions?
Well, the term we use nowadays largely is bipolar disorder. Historically, that was commonly known as manic depressive disorder or manic depression. It's an incredibly difficult condition to manage. Essentially, it's the term bipolar is a reference to the two poles of mood that the patient experiences. So the highs, the so-called hypomanias, or indeed the manias. Hypomania refers to the milder form of mania, whereas mania is the completely uncontrolled form of elevated mood. And that can switch in time to very low mood and depression. It's uncontrollable, it's unpredictable, and it's long-term. It's incredibly destructive. So on the one hand, we know about the creative aspect of mood disorder and manic depression, bipolar. Historically, that's fed, we believe, countless works of art, poetry, literature, painting. But on the other hand, it's incredibly destructive condition to have. There are countless consequences from a social, occupational, financial point of view. We know nowadays statistically that for example, the suicide rate is more than 6% over 20 years following diagnosis. The self-harming rate is about 30-40%. That's massive. So that's something I, as a general practitioner, deal with an awful lot, the long-term sequelae, the long-term fallout of this condition. The condition bipolar we divide into two at the moment. So bipolar 1, which is categorized by one or more episodes of overt mania. So overt mania when there's this utterly uncontrolled, severe form of unpredicted mania that ends up almost certainly requiring treatment to stabilize. In the longer term, we talk about mood stabilizers, psychotherapy, all sorts of things that can give balance, but it's not. One can't aim to flatten things, nor should one, as we said, want to do that, because we want to preserve the person's personality and energy and drive and creativity. So it's really with each patient, it's partly driven by what the patient wants as well, how much they do or don't want to take drugs, how much circumstances dictate whether they want to be treated or not. So bipolar 2 has come to describe patients who have less severe episodes of mania, so hypomania. These often are more copable with, they're less likely to end up in someone being admitted to hospital, undergoing emergency treatment, sometimes at worst, sometimes even ECT, which can help people when they're at the severest end and nothing else works, nothing else helps in terms of drug medication. So, but we categorise in terms of numbers of episodes that someone experiences and severities of episodes.
Do we know what causes bipolar?
Well, the answer is we don't. But we know an awful lot about, for example, the genetics of inheritance. So there's certainly a genetic component. There's inevitably an interplay with the environment. As with depression, we know it's through countless studies that it's something to do with brain chemicals, neurotransmitters. At a very simplistic level, we know that low levels of one neurotransmitter called serotonin are associated with lower mood, and indeed we have drugs called serotonin reuptake inhibitors. So these are drugs that boost the amount of serotonin. But it's not as simple as that. It's much more complicated. And I think increasingly it's thought that the effects of these drugs on different people has a different effect on different people, which probably explains why they're more effective in some rather than others. So although one can think about it, and sometimes it's better to describe it to patients as a boosting of chemicals. It's a sort of natural process of restoring mental health and stability. The truth is it's much more complicated, idiosyncratic, and unpredictable.
So Andrew, I get a bit concerned about, you know, the link between creativity and mental illness, and I wonder whether sometimes it's a cliche. On the other hand, we know from people who've suffered from what we would now call bipolar, people, I suppose, like Sylvia Plath and Van Gogh, you know, that there is a link between mental health and creativity. What do you think as a GP?
I think there undoubtedly is. What I see more of is the destructive element of it, where people need treatment, benefit from treatment, but I'm also aware that people, particularly experiencing the milder forms of mania, so we call hypomania, where there's this almost, someone described it once as seductively effortless energy, ambition, and creative ability that can be harnessed. Whereas if one becomes overtly manic, which is a far severer form, then one can't control these feelings, these thoughts, these so-called racing thoughts, flight of ideas, the sucking in of all sorts of information and creation that is impossible to put down on paper, put down as music, put down as sculpture. You can't do that, and the destructive side takes over. But that also is the case with depression. So certain levels of depression produce an ability to write, produce the impetus and energy to write, whereas if one becomes too depressed, everything turns inward, and the patient cannot produce, cannot create, cannot sometimes survive or exist, and needs help.
One question I wanted to ask you was whether there's a sort of a danger in prescribing certain kind of drugs that can impede the creative process. So for instance, this may be a cliche, but lithium, I've spoken to some people who said they didn't want to, famously Stephen Fry says, I don't want to take lithium, because the main is part of him. The creative energy is part of what fires him. And the worry is that if he dampens that down, then he loses a sort of vital part of himself. Can that happen?
Well, I think it does happen, and I think when it's necessary, then it's necessary. When someone is so dangerous to themselves or others, then you have to treat. But at other times, I think it can, and this is the paradox, that it can deaden, someone's called it a deadening of the sensibilities. So you end up less, some people describe it as feeling less alive, less energetic, less free with these racing thoughts. But then at what price? Is this paradox of stability, safety, and someone feeling calmer and less liable to these massive shifts towards either mania or depression.
And Stephen Fry says, I'd rather live with the angels as well as the devil. Do you remember what
I brought this along. This is his first autobiography. Moab is my washpot, and he's famously. So he's talked about, as you say, not wanting to be necessarily treated or treated long term, and this, again, harnessing the energy that this provides him. And he describes, this is him in his own words, it's not all bad. Heightened self-consciousness, apartness, an inability to join in, physical shame and self-loathing, they are not all bad. Those devils have also been my angels. Without them, I would never have disappeared into language, literature, the mind, laughter, and all the mad intensities that made and unmade me.
Andrew, we've come a long way from John Clare and his struggles with mental health. And just hearing you talk about the positive side of this is, I think, really important.
I think it is, and I think we've talked about the pharmacology and these massive advances we've made, but I think the biggest advance of the last 50 years or more is this destigmatizing of mental illness in general, and bipolar disorder in particular, that people can now talk about it. People can now talk without feeling guilty, because there's no reason to feel guilty, can talk without shame, there's no reason for feeling shame, and can seek treatment, can seek help, and can seek support and understanding. And that, I think, makes the biggest difference long term.